did release in December, and this is an updated one. And then inside that is an executive summary, kind of highlighting some things that are in the analysis.
Okay, and there he is. That looks like the actuary. Was it actuarian?
Actuary?
The actuary needed a cup of coffee.
Yeah. No, but the actual title though. You're an actuarian. You know.
Actuary.
Actuary.
Just actuary.
Actuary science.
All right.
It's a person who digs math.
So let's go ahead and call this workshop to order. It is officially 3:04 p.m. And well, usually the superintendent gets something started here. I don't have an agenda, so I don't know who's the opening.
First page
The
of
first
the,
page
Yeah.
is
Oh,
Second page, yeah. Right before, right there, yes, sir.
There we go. Opening remarks by the superintendent. You are recognized.
Thank you, Vice Chair Melendez, and I'm excited this afternoon for our Health Services team to provide an update for you about all things related to our Health Services plan. We'll start with Mr. DePicot with Provinsure for our advisor's financial report, followed by Barry to give us some additional insight from our data. And Kenneth will follow up with the Center for Employee Health update, and then have discussion with the board about questions, answers, and next steps moving forward. So I'll turn it over to the team.
Great. Thank you very much for having us, and we'll got a lot to cover, but we'll get through it concisely. If you'll move to page 4, the biggest takeaway from this is in the first kind of chart on your upper left-hand side. About halfway down, it says PEPM, that's per employee per month total expenses. You'll see that before we took over the plan, it was at 811. And then we reduced that when we came on board to 761, further reduced it to 701. And we're all wondering, why is it at 811, okay? And so Barry is going to get into some of those details, and Jay is going to also talk about that. But in short, there's a good story, and the numbers are the numbers have actually been going down since we took over the plan. It is the payment schedule that is causing that to look that way. So at first there was a lag when we took it over, and now there's some catch up going on. But overall, your utilization and your numbers are trending in the right direction. And Barry and Jay will give you a much clearer explanation of that. The March report is not done. This is through February. The March report is not done and is already showing evidence that the numbers are going down. On the next page is the rolling 12 months, and the number that I'd like for everybody to focus on is kind of on the right-hand side in blue, about halfway down, the 104. So we are, our expenses are about 104% compared to our funding. And then we go to the following page, and that is for this plan year, which started October of 21, and it's for the first 5 months, and it shows we're at about 103%, expenses about 3% over funding. Barry?
Real quick, on
Oh,
page
yes.
5, there was like a big spike there in September. What happened there to cause the cost to go up so much there? Did we do like a capital expenditure, or did?
no, usually at the end of a plan year, when deductibles have been satisfied or out-of-pockets have been satisfied, it's very common to see a bump in activity right before those items reset.
And that's also for the teachers, the staff who's out of school over the summer.
Right.
So many people go and have services done because they're off from
Right.
school.
Keep in mind, those claims that were, and we're going to dwell on this, incurred date and paid date, but the claims paid in September were incurred June, July, and August, when the teachers have time off. So it's not unusual. That spike is not unusual.
It's very typical of our plan.
Barry?
We do have, as we have, we list those claims that are above $200,000. That's an arbitrary number. Mr. Bass, we're on page 7.
Yep, got it. Thank you, sir.
And this is an exposition of the large claimants that we have currently. There are 2 on here that with any luck will be reimbursable under the federal program because COVID was involved. But not discounting those, the total of $5 million is fully 20% of the total cost to the plan. We want to move on. The next slide is a title slide about data analytics. We promised the board when we took over that this would be a data-driven plan. And while y'all were not here when we took the plan over, the first controversy we had was who owns the data. And we had to rely on your administrator, at the time was Cigna, to provide us data, and it was complicated getting the information. But we've long believed that we need to look at data in 3 phases. The first is finding credible data. We did inherit 5 years of data from Cigna, so under their model of operation, we could draw some pretty good conclusions. The data was considered credible because it went back over a long enough period of time. In the first plan year under our team working, which started in October of 2020, the data, Mr. Thacker, the data pertaining to the way we are managing the plan was immature. We didn't have enough time to draw much in the way of conclusions about the success of our work. Mr. Thacker, we're on page 9.
Thank you.
We didn't have enough data to draw accurate conclusions. We are now moving into phase 2 where we think our data has been pretty accurate. And we can now start reviewing that, looking at the data, and see what needs attention and what doesn't. So we are just now entering the phase 2 of our analytic work on the plan. The next thing is to use that data to impact future costs. And what I mean by that is looking at data to address real-time issues as they emerge and to draw conclusions over financial activity that will occur in the future to see if we need to ally resources and align them with emerging issues. Some of these issues we can do something about. Some of them are just the nature of your population. You know, we have a very high female population. Maternity is going to be a big number. Unfortunately, breast cancer is going to be a big number. Now, between those two, I don't know that there's anything we want to do necessarily about maternity other than make it a more pleasant experience for ladies. But other than try and control the cost of that process. With breast cancer, however, there are new sciences and genomics that are coming on board, and part of our responsibility as your advisory team is to stay abreast of the cutting edge and not bring you false hope over immature science, but to determine, and that's why we're so glad to have Kenneth on our team as an active clinician, is to assess the viability of new sciences and how they might come into play in our plan. So in phase 2, we've looked at the claim data, and as Ashley pointed out, we started the process with some concern for what appears to be increasing costs. And that caused us to work, oh, I'm sorry.
I'll run the slide thing.
Okay. I'm sorry. Thank you.
Take away the clicky thing from
Where's my teleprompter? We had to realize that on a cash basis, the plan started heating up, and that gave us concern for the cause of that. And I think it's important that you understand that a claim incurred is the date that the service was provided. The paid date is the date that ultimately gets paid, which means the provider has to package it, present it, send it to our repricer, it goes to the TPA for payment. And there is, as Ashley pointed out, a lag in that. So if you ask me how your plan's doing, I'm going to look at incurred data that has to be credible. It has to be long enough so that we can see the trends. But if you ask me, how's the health of our plan, I would look at incurred claims. From a financial perspective, we can't ignore the financial aspects of the timing when the claims are paid. And Ashley alluded to the fact that what we see as seemingly heating up of claims has to do with some of the lag that should have been paid last year leaking over into this year. We expect some. We've had more pour over from the previous year than probably should have happened. So keep that in mind, that there are two ways to look at data. The incurred, which is utilization of what's going on, and the paid. And as I'm going to have Jay comment on this next slide. Carolyn, would you pop the slide? Incurred precedes paid. The claim happens, and then it's paid. Over time, they should come close together and be reasonably in sync with each other. Jay, our actuary, would you comment on?
Sure. This graph starts with information as of September of 2020. And it's on a rolling 12-month per employee basis. So the figure that you see that is September of 20 is actually a year's worth of data from October of 19 through September of 2020, divided by all the enrollment over that time frame. All right? And then each step that you move forward, you're dropping off an older month and picking up a newer month. All right, so on March 21st, this data point is April of 2020 through March of 2021. All right, and the blue line is incurred claims. The red line here is paid claims. So ultimately, and over time, they will become one. Ultimately, all claims that are incurred get paid. But at any point in time, there's a bit of a gulf. And what we saw last year was that we were incurring claims, but we weren't paying a lot out. And now, in the most recent time frame, particularly this last quarter, it's flipped to the other way. We're paying a lot more claims than we're incurring. Okay? And Carolyn, if you go to the next slide, what I did with this is simply remove the pays. Okay? So this is just the rolling 12 incurred claims. And the takeaway that I want you to see is that this is completely downward sloping. All right? The trend is in a good way, meaning that we started out here and if you put a trend line through this, it would have a negative slope to it. All right? So we are incurring claims at a lower rate than we used to. Questions about that?
Could I just, go ahead.
Is that the dollar value of the claims, or is it the number of claims?
The dollar value of the claims on average over the enrollment.
Let me just make a statement, and tell me if I got it or not, if it's true. On September 20th, for the prior 12 months, an employee's claims were $700 on average. In February of '22, for the prior 12 months, an employee's claims were $625.
It's closer to 615, but yes.
Well, that's,
But it's
so
not.
for, in a 12-month, actually more than 12 months, in 15,
About
16
18
months,
months,
18 months going forward, per employee, the cost, the claims went down not quite $175, 10%. Incurred.
Mr. Melendez, you had a question?
No, I was asking earlier.
Oh.
No, and the other thing is also is, I know sometimes claims get challenged. What is because just because it's incurred, sometimes, they get challenged for two things, they try to reduce the price of it. That's something I'd like to look at too, because I don't think I've ever seen a bill fully paid, at its face value. Medically, you know what I mean? So what is the percentage of paid versus the percentage of the actual incurred payment? You know what I'm saying? Like, do we ever challenge these enough? Do we just, okay, here's the bill, we're paying full price?
Well-
Is the TPA or somebody in our system somewhere kind of going through there and going, you know what? It's not $100 a Band-Aid, it should be $12 a Band-Aid. You know,
That's a
crazy
that's a
too,
good
but-
question. That's a great observation, and one of the unique characteristics of our approach to managing the health plan is that we have much more say in dictating what is paid as opposed to just having been presented a bill and going, oh, that's the way it's always been. So we are, to a much higher degree, and certainly with your team, managing actively what's going on. And we're looking for those types of aberrations. But you've alluded to the ledger domain, if I will, of the traditional insurance markets where hospitals can bill and not expect to get even close to what they bill. You know, there's these
Charge master.
charge masters, and then, you know, the insurance industry comes to you and says, hey, we got you a discount. You know, so part of what we're trying to do is to make this a lot more transparent and active management.
So who's responsible for doing that? Is that the TPA's job to challenge each claim? Or like, because we got like a soup of like medical consultants.
It would be
and
ourselves
stuff.
in this case, though, right? You guys are managing the three aspects outside of the district, so it would be like you guys selling yourselves a $100 Band-Aid.
Well-
So that's not, that would be avoided in this situation
Right.
at the district.
Right, you know, I was interviewed this morning by Cynthia Foster's team, and she's part of patientsrights.org, and they're in transparency. And the comment I made, and I'm not going to pick on any traditional insurance company, they're doing exactly what they're supposed to do, but they're amenable to their stockholders instead of the clients. And I said, if insurance company A overcharges a client, have they overcharged the client? And of course, that's a rhetorical question because the answer is yes. However, if insurance company A has a wholly owned subsidiary that overcharges the carrier, and the carrier pays that bill with money they get from the employer, are they not in fact overcharging the employer? And you know, I could talk for 3 hours about all of that, my suspicions, I would say, about the layers and layers. You know, United Healthcare owns 633 companies. Think of the opportunities to hide cost and profit in that type of a structure. So transparency is what we're about.
As far, I think he was asking about how do we determine the amount gets paid, Barry? So when a hospital bill comes in, how do we select how much gets paid of that? And it's in our contract system.
Who's looking at the actual bill and
Well,
analyzing and making that
in
determination?
evolutions, our network partner reprices the Tier 1 and Tier 2 claims to a specified contract. And in Tier 3, we direct and dictate that we're going to pay 150% of what Medicare would pay. And that therein lies when we get into the argument back and forth, you didn't pay us enough. Yes, we did. You know, we're trying to pay a fair cost.
So
So,
in that first scenario, there's no bickering because there's a direct contract and it's negotiated at a great rate.
So you have like a pre-negotiated contract for all the
Yes.
services in
Yeah.
advance?
Yes,
Yeah.
with the providers, so the hospital system and the doctors, et cetera, we have a predetermined rate we're going to charge. Then there's people at the third-party administrator who review the claims to make sure that there's not a claim that's in there that
Or to-
should not
or to
be.
So
look
we have like a pre-approved, like super bill, basically, essentially. So a
No.
super bill with all the different, because how do you even know the ICD, how do you pre-negotiate?
All the
those?
systems.
There's a gazillion ICD codes. Do we
It's
have
all
like,
built in the systems.
well, our,
That's
Tier
amazing.
one, Tier two, Tier
well,
three,
well,
right?
the
no,
nice,
but yeah, but it's a very technical question, because my wife used to do this, and I used to have a healthcare billing consultant. It's not that simple. When you do ICD-10 codes, you get a patient, yeah, you can do an office visit, and pre-negotiate an office visit, but when you actually diagnose something and say, okay, you got this, this, and this, they bill you based on your ICD-10 code. They look at the
Correct.
code and go, okay,
That's
this is what
right.
happened,
That's correct.
So-
whatever.
Not on the
And that-
ICD-10.
Not on the
It's-
ICD-10. So
yeah.
in the hospital, you're correct. In the hospital, the ICD-10 is the diagnosis. The hospital, we use what is called the DRG, Diagnosis Related Group. And that's how it's negotiated based off of Medicare. In the facilities, in the outpatient facilities, like the doctor's offices, it's based off of the length of the visit, and then the services that are provided, like if a ultrasound is done, or
Episodic care kind of
yeah,
thing.
things like that. But what you're talking about specifically, the inpatient hospitalizations, where you're talking about the ICD-10s, which are associated to the DRGs.
You know, to that point, we just noticed a pattern where one of our partner hospitals has a primary care doctor housed in a hospital facility. And we noticed the pattern that they're billing based on an outpatient treatment as opposed to a primary care treatment. Well, we got to straighten that out. But in the past, you'd never know that because we didn't get that detail of data. But we didn't go code by code, what are we going to pay? That's the beauty of using a multiple of Medicare, because that's all public knowledge. Not as public as it should be, but it's easily.
Because how do we know that, because part of what my ex-wife used to do, and I give her credit, but that's what she should do. She used to pay the bill, but she reviewed it, and sometimes you look at the codes that were given and say, wait a second, that's not the
Upcoding.
typical.
Yeah.
You know what I'm saying? I'm like, wait a second, you're charging me for 3 things, but yet you got diabetes, they should only be, I'm giving you, because I don't know that detailed as she
No,
is.
you're-
She's smarter than I
you're
am,
right
I'll
on
give her
it.
credit.
You're
You know what I'm
right.
saying?
Spot on.
You only get 2 codes, but yet you're billing me for 3 codes when it should be 2 because it's not jiving. I'm looking at your doctor note, the SOAP notes themselves, and I'm comparing it to what you're billing me, and they're not 1-to-1.
Well,
So
and the.
who's doing that part?
Claims analyst.
Yeah, the other trick, if I can use the pejorative, the other trick is you agree to a bundled price for a procedure, which, like hospital surgical suites typically are billed out in 15-minute increments per 15-minute increment, and that's supposed to take care of everything that happens in that surgical suite. But then you'll notice on the bill, there's bills separate for things that happen that shouldn't have been there, that sort of thing.
That's
So
called
they're
unbundling.
looking for those.
Yeah, so that's called unbundling. So you've got to look for those like little errors, those little nuances,
Right.
and pick those up and say, hey, no, that's denied, that's denied.
So who
There's
does
claims
that? So who
analysts.
does that? Whose responsibility of all the organizations that we?
So there's claim analysts at all the TPAs. That's their expertise, is running through claims.
So the TPA is
And pull
supposed to do
those
that. So
out.
TPA is, before they process a claim, that's why there's a delay in that claim, right? They're supposed to be looking at the claims, looking at the notes, making sure they jive, and then paying them based on what they
They're
believe
reviewing.
or challenging them.
Make no mistake about it, there's still slippage. And early on, one of the recommendations we made was to hire a company that would review itemized bills from hospitals over X amount, $50,000, looking for errors. They call them errors. When it happens 90% of the time, I have a hard time using the phrase error. But,
And just the reason why I did say that is because to me, that was a natural thing. She didn't audit it. Every single bill that she got, she went through and confirmed it before payment, and that's why there was a delay of payment. To me, it sounds like we don't really do that until we see something that looks a little bit off or something like that. So we're not going through every single bill and some.
no, we see the things that are off because they're going through every bill, and we're picking up the things that are aberrant.
They're following best practices out there, so it is being looked at, and excruciatingly so.
So we set about the task is slide 14, Carolyn, if you would.
How are you looking at it? I mean, are you like putting it through a software? Is there one specific person who's looking at every single bill? What's the process and mechanism?
It is software-driven, and then I want to say our level is at $10,000 human eyes look at it.
Yeah. There's, well, I'll say
So
this,
it's anchored to a specific price for that.
as the system goes in, I think there are certain, based on the DRG code, there's certain things predominantly that they'll see that are upcoded or not, and reviewing those claims. We can get more an exact
Yeah, we can
workflow
get more
process for
details
you,
on that.
but again, we know that that these claims analysts review them, or claims reviewer, and that's their whole entire job.
But we can, if you'd like, we can definitely get more details and talk about what their practices are.
Yeah, I'd like to do that. The next
Okay.
workshop, if the TPA could come in there and stress, hey, this is how we do it. This is examples of what we do. This is what we're looking
Yeah,
for.
sure.
And these are the pre-negotiated rates.
Yeah.
You know.
Very good. Glad to do that. And thank you for your level of scrutiny. It's refreshing from, my history that all too often employers sort of passively rely on someone to make the magic happen. So we're excited that our emphasis on actively managing the plan is taking hold. But we looked at the data seeking some pretty simple answers. How is the health of your health plan? In order to know that, we review incurred data because it's telling us, notwithstanding, the data that we're looking at today still has 6 weeks of claims that have been incurred but haven't been paid yet. But we look at claims based on the incurred date. And where is the money being spent, which means is it in diabetes, is it in surgeries, is it in colon cancer? That also, we use incurred data. Why are the claim payments currently higher than we like? Well, we got to look at, as Jay so well pointed out, the spread between incurral and paid dates. But then the real payoff is when we get to phase 3, which is pending, where can we apply resources to impact future claim volumes? Next page, Carolyn. So first thing is, how is the health plan? And here again, we look at the volume of claims, and we're going to look at the cost per encounter. The volume of claims goes on by itself. There's not really a lot we can do about the volume of claims. People are going to seek services as best fits their needs. We do notice waves, like in the summer, it's more because the teachers are off and can attend to some of their healthcare issues. The cost per encounter is our responsibility and what we think is a driving success factor for us managing the cost more effectively through the resources we've applied and the contracts that we've created. But when we compare encounter detail for this year, it's 5 months, to last year, which is a 12-month period, and we normalize those trends on a per claim per month basis, we do see that the utilization is down for this year, in spite of the fact that the payments are up. But again, that has to do with the lag of taking on responsibility this year for some claims that were incurred last year that perhaps could better have been accounted and paid for in last year's numbers. But we do see some issues of concern. Mental health is up across the board. That is not unique to your situation. Your teacher staff, I can't imagine, we have a teacher here with us, I can't imagine the stress of normalcy, but to go through a 2-year pandemic and the separation from the students, and candidly now the teachers having the added stress of dealing with the stress and mental issues of the students as a result of that. And it's something that we're paying very close attention to, and I'll have Kenneth comment on that here.
Yeah, and so it's actually in my presentation. We talked last quarter about mental health, and we actually increased the number of services at the health center. We added e-home, which is another televisit type of mental health, but we're still seeing across the board, from the substance abuse, the depression, the anxiety, we're seeing it across the board. So one of the things that we were talking about is doing another campaign, but also maybe a campaign about removing the stigma of mental health. Because we did that, and we saw an increase in utilization at the Rosen for individuals using it. Once we helped everybody realize it's okay, we're seeing, at the health center, we're seeing a little bit more of the divorce, also infidelity, things like that are coming to the facility to speak with our counselors about. So we're looking to advise everybody about your EAP program, your e-home program, the mental health services at the health center, and then also with next steps, just to make sure everybody realizes all the resources that you've got and provided for your teachers. And I'm going to go into a little bit more detail about some of the other diagnoses that we're seeing at your health center.
With just the stress of everyday life in the economy and inflation,
Yes.
that number is going to grow pretty substantially over the next several years.
We got to we need to gear up for it.
Yeah.
He's calling it the next pandemic is going to be mental health from this pandemic.
But it's at least, let's make sure everybody understands and remembers that, you guys already put in place for the mental health. So when they realize I need it, and that all your administrators, everybody can remind the teachers about, hey, contact this, contact that, so they can get the help that they need.
Well, but your point about the stigma as well is that it doesn't make you deficient if you're having some mental health issues. Ms. Theo?
It's okay. I'll wait till your presentation.
Okay. You know, the next item, we noticed that mammogram utilization has decreased, and that's something you don't want to decrease. And Kenneth talked me off a ledge because he said, well, if you look at the patterns, they're going to catch up on their mammograms when they're not working 10 hours a day in the classroom or at home grading papers. So again, that's one of those seasonal fluctuations that we anticipate will correct itself over that time period when the teachers have time to take care of themselves.
If we know that, and I'm sure mammograms aren't the only one, what are we doing to gear up for making mammograms easily available, like in the summer, and other things like mammograms that we know are summer types of things where they have time to do?
You know, we've worked on programs, we put together a mammogram bus to actually visit the schools. And I'll let Kenneth comment on that, but.
But if we know summer is if we know utilization's down, we believe it's going to go up in the summer when they got time, where are we putting the bus in the summer that's very convenient for people?
Yeah, we have to revisit that because pre-pandemic, we had taken the bus and put them at some of your various schools, and unfortunately, it wasn't being used.
Yeah, I knew that.
Yeah, so we have to revisit this with our vendor, and I've also had, literally today, a new conversation with a group. So that might be an opportunity for us also. But we got to revisit this because pre-pandemic, the numbers weren't there, and we can't ask our vendor to be there and just sitting there.
Right.
Whether it's the teachers didn't have the opportunity or the time, we were looking at that before the pandemic.
But the
Okay,
members
two
still have the
things.
ability to use the other vendor partners, like the green imaging and stuff like that is still there too.
Okay, two things. With everything that you're showing, I know that you have like increase, decrease, but I don't know what that actually means. So do you have a trend? You're telling me that the mammograms will eventually increase during the summer, but do you have numbers to back that up?
Yeah.
Okay, and two, when you're using the vendor to provide access to mammograms, are they taking appointments ahead of time, or are they just showing up?
No, they were taking appointments ahead of time and also taking walk-ins.
Okay, so do you know what the rate of appointments was? Like,
But the number of appointments?
yeah, from the people that you saw, how many of those folks actually had appointments versus how many people actually did walk-ins? And the reason I'm asking is because you can determine whether or not it's going to be useful. If people are not making appointments, then that means that whatever area you're putting it in is not viable.
And a majority of it was appointments.
It was appointments.
Majority of it.
No-shows or
A
cancellations?
bunch of no-shows, which was, it was a little bit, hey, we put this there, you scheduled the appointments, and then didn't show up. I mean, so we have to, again, revisit that post-pandemic to see what kind of opportunity we can have and make sure that from a marketing standpoint and a commitment standpoint, if you chose that spot, then do everything you can to be there. But the pattern was too frequent.
Yeah, I don't think when it comes to mammograms, the issue is access, because they can go to their doctor, they can go to green imaging. It's time availability, although that doesn't mean that we couldn't have a program that said, hey, for 3 days, we're going to have a mammogram bus at the clinic, at the health center. Let's see what kind of volume and make it easier.
So if we know that our patients or our employees are getting mammograms elsewhere, then why are we even spending time on the bus?
And that's a really good point. And that's what we were recognizing, that they were going to other places, but we were also trying to make it convenient to those who were not going. So that's why I'm saying we've got to just reassess it post-pandemic. Take a look, do we start again at the health center? Because that's what we did. We started at the health center with the bus. Then we pushed it out to a bunch of your schools, working with Lauren and Latasha to say, hey, this is the one that has easier access from a high school and a middle school to get people there. But then we recognized they're making the appointments, but they weren't showing up. And that's not fair to the vendors. So we really need to look at it again. But you're absolutely correct. With the outpatient centers that are there, the green imaging that are there, they can make it as convenient as they want to. But does that make it convenient for everybody versus having it at the health center?
Before we go on to the next one, I just want to recognize that on the phone with us, we have Scott McEwen, is our data analyst. So he is the one that we work with to slice and dice and to get all of these. So if we want to know all of the history of mammograms, what has been the average per month, historical for Osceola, Scott can pull things like that.
But even more important, it's like, yes, I love making things accessible, but if 87% of the women are getting their mammograms in another way, and you have, whatever, 14% who are not using what we're giving them, then those 14% of women aren't going to get them if you literally went to their classrooms with the imaging and said here. So there's, I mean, and I'm not trying to be funny, I'm just saying it might be that those, I guess I want to know how, not I want to know, but what we should be trying to figure out is how many people are getting their mammograms. And if that number is a large number and we know that these 14% of women are just not going to do it, then this might not be a utilization.
That's how you look
high-
at data and
exactly
draw
right.
conclusions.
Because
What was it before the pandemic? What was it before
Get
the
that
pandemic?
number for us?
Yeah, that's, I mean, that's a good variable to throw in there as
Because,
well, of course.
you know, kind of like piggybacking what she was thinking about, does the bus even make sense? Because obviously I'm not a female, you know? But like if I do, if I do like prostate screening, right? And there's a bus for prostate, I'm gonna feel uncomfortable because I usually feel comfortable like within my own provider. My provider telling me, hey, look, you know, it's your annual screening, you need to do your prostate. I think in that setting is a little bit more appropriate than just randomly going to a bus, hey, let's do a prostate. I'm like, because that feels kind of invasive. I'm like, wait a second, I don't know if I just want to go randomly do a prostate screening with somebody I really don't know or anything like that. I kind of want it to be in my continuum of care where I have a relationship with my provider. My provider's like, look, Julius, you're doing good, you're not doing good. Hey, look, I think it's time, you know, and that person can encourage them. So I don't think that, I mean, again, I'm not a female. Maybe they can be okay with mammograms, you know, willy-nilly anywhere they want. But at least when I do prostate screenings and whatever, I want to kind of have it in that continuum of care of the setting that I'm normally showing up all the time.
Yeah, so
Generally,
in your
women are used to
scenario,
going
you're
somewhere
exactly
else.
Correct.
Okay, so that,
Because it's a big machine and.
But our,
By the way, it's 68% of women aged 40 to 75 have had mammograms. So 32% of women are not.
So you're talking about a PSA and a
Thank
digital
you, Scott.
rectal exam. That's a little bit different than the scenario we're talking about with the mammograms, because we need a huge machine, a 3D machine, to do that. So the patient, the female patient, has two choices: to either go to an outpatient facility, to a hospital outpatient facility, a freestanding facility, or to the bus. They can't get it.
And it's
at
going to
their-
be a stranger.
Yeah, it's going to be a stranger. They can't get it at their OBGYN or, I don't think there are any,
But I
or
think-
even to their primary.
Right, but I think our efforts are not geared to the 68% who are handling their business. It's geared to the 14% who, because of socioeconomic determinants of health, have some resistance or reason to not get what could be a vitally important test.
Can't you just email the 32% and just ask them what their hesitancy is or what their preference is?
You know, we have to be careful. That's a great idea, and it's not just for this. It's for diabetics that are not conforming. Then you run into PHI, private health information. How'd you know I'm this and that?
Yeah.
We know, but we're not allowed to
By
act
the way,
on it.
my apologies. It's 68% have not had.
Oh, that's not good.
That's not
Right.
good.
That's
No,
very
it's-
bad.
So remember during the.
I just looked at the metric again. I apologize.
Yeah.
All right, thank you for that clarification.
And Scott, do we know how that compares just nationally?
But Scott, is that?
Yes, give me one
eligible?
second.
That's in your report.
Yeah, and two
Some
is that
things
there is a
are-
schedule that certain women don't need it every year, so there's that whole,
Yeah, I mean, I guess that's important to find out, but if 68% of our employees are not getting screened for cancer, which is it's one of the top, cancers that you can get, then that's a huge concern.
And
I don't know if the bus is going to fix it.
Right, right. Well, you know, at one workshop, we suggested having a floating sub that would relieve the teachers, and that seemed like a kind of a good idea. But at one of our board workshops, the Veteran Teachers Association said, we'll go in and relieve the teachers. You don't even have to hire a sub,
But it
they would
sounds
volunteer.
like-
Because where would you find the sub?
Right.
It sounds like the issue isn't necessarily availability, clearly. I think the issue is maybe like a conversation, possibly
Motivation.
cultural. That's a behavioral change, and you're not going to solve that with adding more buses or
No.
having subs come in.
Well, it has a humanitarian aspect to it, to make sure that people are taking care of themselves, but that will reflect on a financial issue for the working of your health plan if we're not catching the cancers early and that sort of a thing. And that's the type of logic and thinking that we're trying to apply here. Mr. Thacker, you had a comment that,
Well, just to restate my question, because it was not a mammogram question. It was things that can be done in the summer. How can we set ourselves up? And I don't care where it is. I don't care if it's green imaging, I don't care if it's a bus, but that where we can help people and say, these are somebody's got a list of mammograms and
Annual
prostate
checkups.
exams, physicals, whatever that list is, it's 10 things that we know need to be done, that we know based on history are being done during the summer. If it's good for 32% of the people to do it during the summer, it's probably good for another 32% that aren't getting it done. How can we help educate and avail those things? Like I say, my question was not a mammogram question. It was-
Right.
I didn't mean to get all off track on the bus and everything else. It was proactively doing other things we can do during the summer, and I don't know if we're doing that or not, but I hope we are.
From the health center perspective, we are reaching out to those individuals that we know about. The patients that are coming to the health center, if they haven't gotten a mammogram, then we're reaching out to them. If they haven't gotten a colorectal screening, we're reaching out to them. If they're not availing themselves to the International ElectRx program, we're reaching out to those individuals.
see, they can do that because they're the provider. They can do it because they're supposed to know all that. If I call, I ain't supposed to know that stuff. So that's one of the beauties of having a health center. So, next slide. Oh, it's up. Thank you. The other thing we look at is how are our cost containment strategies working? And as you might guess, that's a fluid concept. And some of the items, we're paying more per unit than we were in the past, and there's a good number that we're actually paying less per unit. It's a dicey topic because sometimes the price per unit could be as a result of intensity. If I go to see a primary care doctor and all I get is just a regular bit-bap, kind of a physical, that's one thing. But if I'm getting stitches or if I'm, if there's more intense services in the engagement, then that, of course, would drive the price up. The other thing I wanted to have you observe is one of the great things we did was tie your reimbursements in the contracts and for Tier 3 to Medicare. Well, Medicare had a 4% increase in reimbursements, and it's using simple math. If we're paying 150% of Medicare, Medicare goes up 4%, our costs go up 6% because we're paying the multiple. And, frustrating, but that is ingrained in the system and something that we have to take into consideration. Oh, no question about it. So the second question, the answer, how's the health of your health plan, as was pointed out through the Jay's chart, it's in good shape. And we can see improvement as the paid numbers come more in alignment with the incurred numbers. The second area is where's the money being spent? We've seen some areas that do have an increase in expense, and this is a combination of utilization and in some instances, increase in cost per service. But again, mental health, and we have to keep in mind that it's not just the direct cost of mental health. It's the ancillary, stress is a mental health issue, but if it creates chest pain and drives you to the emergency room, that's a ripple effect. And we're looking at that cohort, and we have found, as it says in the slide, those people who have had mental health encounters, which is a direct engagement for a mental health issue, their average cost in general is $757 per member per month, compared to 2/3 of that for the general population. So we know that's a cohort, I hate that word, but it's a cohort that we need to focus and pay some attention on. You want to comment further?
No, I mean, again, we'll go back to my slides when we get there, just reinforcing the type of diagnoses that we're seeing across the health center, which we talked about last quarter. Now we're seeing it in the financials, and I think it comes out to like $1.3 million extra spend on the mental health side, if I remember correctly.
Were you able to extrapolate like what the mental health crisis is? Is it depression, anxiety? I know I see here substance abuse, but is anxiety, do you know
Yes.
which, how many?
Yes.
Okay, go ahead.
Show it.
And a lot of that is in
here.
detail is
Okay.
in the reports.
But also talking to the various counselors, just to listen in as to what else is going on. So somebody might come in for family issues, but then on top of that, they have anxiety, they have depression, they have anger, they have fear.
Substance
All of
abuse.
those, and substance abuse, all of those variables associated to it. But again, the infidelity, we've seen more and more of that too, which is concerning.
Cancer activity is up. Last year, colon cancer was number 4 on the list of cancers. This year, it's number 1
List of cancers in the country or in our plan?
in your plan. And so we're looking into that. Breast cancer continues to be prevalent in a high female population. And I'm going to get into this a little bit later, but in that particular example, there are genomic science is really coming on board for those types of conditions. And the science would suggest that a significant number of ladies who undergo chemotherapy for breast cancer don't have a prayer of that improving their situation because of their hormonal makeup. And through genomics and using DNA analysis, you can impact and be better determine what's the proper course of action. So we are looking at, you comment on that, because it's,
Yeah.
we're also looking at it in the musculoskeletal area, and I think we're going to recommend a genomic approach to be added to what we're doing in the health center to, again, determine best courses of action and avoid unnecessary surgeries.
Yeah, so on the colorectal cancer especially, when we were looking at some of your previous data, we recognized a lot of the patients weren't going to get their colonoscopies, right? And that's something that should be routinely done at age. So one of the things we recognized too is that a lot of the teachers were saying, I don't want to go do that, the prep, and I have to be put under general anesthesia. So we brought in, and you've probably seen it on TV all the time, the Cologuard. That's very, it's private, you're at your home, you take care of it, you mail it in, you get the results. We get the results. And we did over, I think it was like 400 of those, and 22 of those came back positive. So when we're looking
The
at,
positive just meant that they just needed to follow up with a
so a
colonoscopy.
positive means there's a problem.
Yeah.
And so now you have to go get that colonoscopy so we can positively diagnose and take things out of there, but at least they got that done. So if they weren't going to do the colonoscopy, which is the gold standard, we'll take the second best thing. And we're following up with those individuals, not only the ones who were positive, but also the patients that we recommended and we had it sent to their home and they didn't do it yet. So we're following up with them. Hey, did you send it in? Did you not do it? Are you waiting to do it? Are you afraid? Do you not understand? So we can get that done. And I have that in one of my slides in here about some of the details that we're doing. But 22 positives came back, and so we're following up.
We wish there was something like that for the mammogram.
One day. One day.
Physician services are up. That's not entirely necessarily a bad thing. I think that part of that is a reflection of people coming off of a pandemic where you didn't want to go to a doctor's office where the sick people are, and we're now freeing up. So I think that's kind of a natural tendency. Very importantly, of the specialists for the top 10 or OBGYN, I think that's a positive activity. That we're seeing some catch up from the pandemic. You know, interestingly, the incidence of emergency room use is up, but because of the quality of our data, and I'll have Scott comment on this, we look at appropriate use of an emergency room, which is not a bad thing. What's a bad thing is we have 2 people who have gone to the emergency room for primary care. And we don't want that. But emergency room use is up, urgent care use is down, which is not a good combination.
I'll say it needs to be
And we
down.
could educate about, or candidly, the typical approach would be to put a $250 copay on emergency rooms that you don't have to suffer through if you go to urgent care. That's a negative driver, and it's something that has to be negotiated with the union. The $250 isn't going to break the person because they were going to have a large out-of-pocket expense at the emergency room anyway, but we're very sensitive to the impact the decisions we make have on your members.
So
What's
one
the
of the
current
oh, sorry.
copay for emergency?
It goes to deductible and co-insurance right now.
Yeah, because I'm willing to make an exception for those that get transported there, because you don't choose to do that. If you're
Right.
going in an ambulance or a helicopter, it's probably a red flag or an indicator that it's a proper use of the emergency room.
Not a sore throat, though.
Yeah.
There are some people that take the emergency, that use the ambulance to get to the doctor's office too.
I know, but at that point, then I can't split the hair that much.
So one of the things that we did about 3 years ago, we wrote a letter to one of our partners and Guidewell saying, hey, you guys need to put a place up in Osceola. And they did. And I think Lauren and the team went to the grand opening. That's a spectacular company and facility because they are board-certified ER doctors. They have CT on site. They can do D-dimers, which are for blood clots. They can do cardiac enzymes, so we know if they're having a heart attack. A lot of the things can be done there. Number one, it's cheaper for the associate, your employee, but also for you as a district versus going straight to the emergency room. So that's one of the other things that we got to continue is to show, hey, that was just opened up 2 months ago?
No, 6 months.
Has it been 6? Okay.
And they
6 months ago.
have tiers, for example, so if you show up with a hangnail, right, they're not going to charge you like an emergency room would charge you. Okay, they're going to charge you slightly more than a primary care visit, but they're going to charge you for the hangnail. And if you show up for a serious emergency, it's going to be at, the appropriate prices,
So
so.
no matter if you have the
If you show up
ultrasound,
with a
CT,
hangnail at the emergency room, they're going to run all these tests on you just in case there's something wrong with
I
the
know
hangnail.
recently at Guidewell, there was, like everywhere else, is a staffing issue going on right now with medical providers, so I'm not sure if that has rectified.
I wanted to mention that a lot of our urgent care is closed on Sundays in the last few months because of that provider shortage, and they've just recently reopened, so that might have something to do with our urgent care numbers being down, especially since our employees like to go on Sundays.
Yeah. We didn't factor that in.
I would say this, and most of your emergency room utilization is appropriate. Scott, you got a number on that? It's in your report, but
Yeah, I think it's 89%. I'll have to pull it up, very sorry.
that's fine.
Yeah, but that's the kind of stuff we want to look for. We're going to look for the reason why are they going to the ESOPR so we can help address and guide them to the appropriate source, the resource.
Especially, what we call frequent flyers. You've got 2 people that have been to the emergency room 6 times this year. That's a pattern we need to figure out.
Are you allowed to have
Or
a
they do
conversation
have-
with them?
Yeah.
So if it is a health center associate, yes, and we will. So as we look at the data and some of the things that I'll show you, we can extrapolate, okay, who do we need to continue to work on? Like what we had shown in the very beginning when we recognized there were areas that needed improvement. Now we can actually recognize, hey, here's 9 people that are falling out of it. We can identify who those 9 people are and then get them into the care. Maybe it's they didn't understand or didn't know about the ElectRx program and they couldn't afford their diabetic medication, or they couldn't go get a test done because they didn't know about the green imaging program. We just don't know. But at least we know who that associate is. And one of the things you'll see in my presentation is we're capturing more and more of the market share. When I'm talking about market share, I'm talking all of Osceola teachers. More and more are starting to come to the health center for specific diagnoses like asthma, like diabetes, like hypertension, the things that are costing the district money.
I'm sensitive to our time here. I don't want to skip over any important parts, but page 19, our injectable and infusion drugs, we had 2 drugs this year that cost this plan $1.1 million that were not even on the market a year ago. And I'm sure these are miracle drugs. The good news is both of those, although very expensive, were short-term in nature. The treatment is resolved, and at least for those 2 people, we don't have to anticipate ongoing problems. But we're looking at opportunities for that as well.
Yeah, so one of the drugs is actually, you'll see it on TV, it's called Tepeza. You've probably seen it about 1 million times on TV for people who have thyroid disease. Their eyes start bulging out, and then it causes some vision problems, which is great. It's great that we can actually help them with that issue. But this is an IV infusion drug that ranges between $400,000 up to $850,000 for the 8 treatments every 21 days. So we're looking at a program. We're testing it right now to see if we can find ways to move that cost to the manufacturer. And then eventually, as we get into your health center, the pharmacy program going, I'd really like us to explore some of the IV infusions, because you also have patients who have Crohn's disease. They might be on Renflexis or Remicade, those type of drugs that can be IV infused. Well, we can partner with the pharmacist, do the acquisition of that biologic, and then we have a company that would come into your health center to do the IV infusions. Well, Kenneth, why don't you guys just hire IV infusion nurses? Because those nurses are very expensive, and right now we still have a nursing shortage. So we would partner with somebody, so then they would take on that liability also, and that they would come in and that IV infusion would be provided to your associate in your health center. And that's down in the future.
It's not a concern, but we have to recognize space limitations in your health center, because with the introduction of an infusion center, we can look at other therapies. There is a growing therapy for diabetic infusion for type 2 diabetics, where ultimately they could come in for an hour and a half infusion once every 6 weeks and not have to take the Januvias, the Jardiances, the Trulicities that are eating our plan alive. And I know there's space limitations, but infusion capability in your health center makes an awful lot of sense.
And so this partner we're also looking at is not only the IV infusion in the facility, but even at the home to do IV infusions. So we're looking at every avenue to make sure that that can be done.
So the cost that we're looking at here is for 2 specific medications, but what percentage of the population is on injectables?
There's injectables and infusions.
I'm sorry.
If
Yeah.
Scott.
So these are listed
Very small.
together. Does that mean that they might be different medications, but
yeah.
but
Different medications.
but the way that they're administered is the same?
Those are those were 2 infusions.
Well, in injectables, a single shot, in infusion, you sit there and go through a transfusion.
Some doctors still maybe
Okay.
go to their office for the shot. It all depends on how is it a, what do you call it, Kenneth?
Oh, yeah, subcutaneous into the
Subcutaneous.
muscle. I mean,
I'm
all
just
the-
trying to figure out how much
Can you
sense it
bill it?
makes to have that specific service.
Yeah.
That's what I'm trying to gauge.
Scott, if you can isolate infusion and injectables, and again, we're not going to wait for you to do it right here, but that's a request from Ms. Castillo that we get a little bit deeper information on infusion and injectables as a percentage of the population.
And if it can't be justified, we wouldn't.
Is there like a substitute for it or something like that, or is it?
So, yes, so there is, for some of the biologics, there are some substitutes, but it really depends on the patient. So if a patient started on, say, Remicade, they're started on the Remicade, and then, hey, they've done well on it, and then we want to transfer them over to the other substitute, which there isn't that much of a savings now. And you're going to see more and more of these biologics coming out that I'm hoping that the prices will come down, but there's not that many of them. But you are exactly correct. We got to find those resources, get them out to the specialist to make sure that that's being ordered. But the more we can control the IV infusions, the better we're going to have the ability to make those recommendations
And
for the
manage the
substitutes.
cost.
At the initial
Right.
onset of it.
And an injectable, you've probably seen on TV, you've seen Humira, you've seen the Enbrels. Those are injectables that is administered in the office versus an IV infusion, which is going straight into the line with a little bag, and you have to sit there for about an hour and a half.
Right. We are looking at a couple of transplants looming on our horizon, and those are always expensive. We're working with multiple Center of Excellence partners to do everything we can to anticipate and pre-plan and limit the cost exposure on those.
Oh, sorry. Oh, he's still on screen too?
So on slide 20, and again, in deference to time, you can review this, but what we're showing is the current plan year on the right compared to the last plan year. And again, we're comparing 5 months to 12 months, so these numbers have kind of been normalized. But we're looking at areas where the cost has gone down and where the cost has gone up. We're saving money in the red here, the surgical implants, the mental health, the maternity, the PET scans. We're paying more money for some of these other items. And in every area where we're spending more money than we were per encounter especially, we're looking at it to find out why. Is it an intensity issue? Is it a contract issue? What's driving those costs?
And one of the things I want to look at too is, some alternatives for maternity care, possibly like at-home births and also birthing centers. So we'll take a look at that.
But there's a confusing thing, and I'm sorry to bring it up, I know, but the emergency rooms on the prior slide said they're up 85%. But on page 20, it shows the number of counters at 816, and this year 469. It shows the number of counters going down.
Versus cost. The one on slide 18 is the costs are up 85%.
Oh,
And one's
claims
the
paid,
encounters.
not- claims paid didn't have to be, okay, I got that.
Encounter, I know. It's a couple of weeks of doing it, and we have to get in our head too.
Pharmacy continues to be a bright star. We have a stranglehold compared to the past on your pharmaceutical issues, and this is inured to the benefit of the health plan financially and to your members who are able to take part in pharmaceutical resources where they can pay nothing or very little for their pharmaceuticals. One of the things we look at are areas where we can improve, and we ask ourselves, how many savings opportunities have we lost where we could get somebody to go from one pharmaceutical to another? And now keep in mind, some people, because of their physiology, are not capable of using some lower cost pharmaceuticals. That's why we have the step therapy and why we have had these other programs in place. But our lost opportunities for savings this 5 months has been $11,000, which is nothing. Means we're really tight on it. In the year prior to us assuming advisory role for your plan, the lost opportunities were $1,125,000, and that's money that was spent that could have been saved through more effective migration management. And there's, again, continuing that, our international drug sourcing has been magnificent. you know, in the 5 months of this plan year, members have paid $1,500,000 in copays for domestically sourced pharmaceuticals. They have paid zero for the pharmaceuticals that we provide through international sourcing. And we do that because Humira is $5,800 a month at Walgreens, and we're getting it for $2,100 a month internationally. So it makes, you know, to encourage people to migrate.
It really is.
Oh, yeah.
It really is.
So just on the Humira, we haven't been able to migrate all of the patients because you cannot get Humira citrate-free through our international source, which many of your population, I think it was like 27, are on that. And the citrate-free just makes it less painful. So we're constantly communicating to see if they source it, and then once they do, we're going to migrate those patients. But your health center is running what we call lost opportunity reports. So say we refer a patient to a specialist, and we recognize that they started them on a medication that, hey, they started it for 30 days, they're consistent on it, we're going to reach out to them to say, hey, you can get that Ozempic, that Trulicity, the Guardians, whatever it might be, through our international pharmacy, and it's going to be free for you, and it also saves the district.
So it's the same exact drug. So we're not talking about like switching like a trade name to like an off-brand name. We're talking the same exact brand name, just happens to be a different distributor. So
But getting back to.
In a different country.
May I ask an additional question? The 2,100, as an example, of course, is that with the cost that it takes to ship it?
Total.
All of that's included?
Landed, yeah. But it's interesting you talk about criminal because, you know, insurance companies, right? When these costs go up, they know that they're going to be able to pass it on to you guys, right? They may not be able to do it this year, they just jack up their rates next year. So there is no incentive for them to fight like heck and say, pharmacy company, quit doing that, right? So that game's already rigged up. And think about 10 years from now when maybe 25% of the employers in the country are going to be actively managing their plan like you are. All right? Can you imagine 25% of the employers out there accepting, you know, $1 million drugs? It's going to get shut down, but
And
it'll
these are
be a while.
high-end drugs. And really, a bigger one is like insulin. I mean, insulin is really, the cost to make insulin is single dollars. And the billable cost for insulin is hundreds of dollars. And it's a critical need for it. You die without it if you're diabetic. And so it doesn't get the big campaign like the Humira because the dollar amount aren't a lot, but the $200 difference is huge for a diabetic.
Anybody guess how much the patent was actually sold for insulin?
$12.
I see.
Oh,
That was zero.
$1.
Yeah.
$1.
Yeah.
But it's selling for $500, $600.
And I think that, I heard a podcast before that it actually costs about $6 to make a vial of insulin.
But the patent
Yeah.
is sold for $1.
Right. So other bright spots are Tier 1 hospital arrangement over the past 5 months compared to the 12 months that we had with that Tier 1 arrangement has generated above and beyond what we saved last year, $337,000 inpatient, $250,000 in outpatient, $100,000 for maternity. And likewise with dialysis, while the volume is up, the cost per treatment has trended down, and we think SCM, our chronic kidney disease partner, has saved $138,000 this year, again, over last year, not over 3 years ago under the prior administration. It's just over improving on our track record from last year. And imaging continues to save money, and the beauty of it is in imaging is every time you save money at a green imaging facility, that patient has gotten a free image, which eliminates the barrier, the cost barrier to having a diagnostic test that could save a life.
And that's really important. Remember when we first started, 2 weeks into it, we had a patient who needed an ultrasound and couldn't afford the ultrasound. It was $200. And so now your team put together this program, and it's giving your clinicians the ability to diagnose your patients properly to get them to the right care and provide the right treatment for them. So that program, on top of your ElectRx program, thank you from the clinician side of it.
For our next step, and hopefully by the next workshop, we'll have a nice report for you. Right now, we're doing an analysis with Scott and Green Imaging on kind of lost opportunities. People that are still having imaging done at outside centers, and then comparing that cost to.
Where's Green Imaging located? Do they have multiple?
Green Imaging is just a name. And so she's like Travelocity for imaging. So Dr. Dickerson, the owner, what she does is she buys time at imaging centers when they're not using their machines. So places that you just ordinarily see, there are downtimes that their MRI, their CT are not being used, and she buys it at a discount. So, yeah, she's a genius.
No, it's really.
Yeah, she's a wonderful, wonderful partner.
So they're all local, independently owned or corporately owned imaging centers, but she had the wisdom, I used to have a client, Club America Vacations, and they did the same thing. They went to Cancun and other places and said, this time of year, 20% of our rooms are empty. Well, we'll pre-commit, to take those rooms at a deep discount. And of course, the hotel gets the ancillary spending on liquor and all that kind of stuff. And she kind of did the same thing with imaging.
Those machines are millions of dollars. And so if they're not being used for every minute, they're losing money. So she's our MD in radiology and.
So when our employees, potential patients, say, I want to use the X-ray machine, they present them the times that they can go in, right? And say, okay, hey, these are the unused times, so now you guys.
Oh, no, they're not limited. It's
So,
whenever
do
they
you want to
they
explain
put
the
them in.
process?
Yeah, so when an employee needs an image, either through the health center or outside, the employee just texts Green Imaging's number.
They get their
and says-
prescription.
Yeah, with the prescription, and what their availability is, and if they prefer a certain imaging center. We have a lot of our women that do like to go to certain ones for their mammograms, and then Green Imaging looks to see for what fits into their schedule and whatnot, and then makes the appointment, gives them a voucher to take with them. They have the image done, and then Green Imaging actually raises the image and sends it to the provider.
It's
It's all
very
done within about
convenient.
10 minutes.
Yeah, it's very convenient. It's so cool.
Yeah. So like for an MRI, there's contrast, without contrast, stand up, all those different kinds. They know exactly what facilities can do what's your availability, do you want to go near your work, do you want to go near your house? And
They don't have a problem with transferring either, too. Sometimes I know, like if I go to a dentist, man, it took me forever to try to get my x-rays because I don't want to go to another dentist and take the same set of x-rays over again.
The only issue that we have is that there's one provider that members love to go to, and there's an issue of that provider not going to the Dropbox place to get the image results or something like that. But we work around it, and Dr. Dickerson works it because she knows that people like to go there. But they're not easy to do business with. They're not like everybody else in how they gather the image.
And
but-
Mr. Melendez, to confirm with that transfer, they do offer discs. I personally use them, and they'll
Right.
tell you if you need a disc, request one and you'll get one, so you can always have the records.
Right.
And so I can travel with that patient.
Absolutely.
So if they go to, so if the clinic gets it too, right? So if they get the x-ray machines,
The doctor.
you guys have the actual source files themselves, not source files, but. Yes.
So we've taken the average cost of a CT scan from $2,400 down to $750. And the MRIs we're paying $475 for, that were dramatically higher
They were
before
about
we.
$2,000 before.
Right, right. Just like we have efforts to try and migrate people from more expensive drugs to less expensive drugs, we also have an initiative that tries to migrate folks from having surgeries that can be performed in a less intense environment. Don't go to the hospital, go to the ambulatory surgical center. And poor migration management before our tenure cost as much as $1,700,000, and we're way down to, right now, we're under about $400,000. But you have to keep in mind that sometimes a surgery that can be done in an ambulatory surgery center is more appropriate to do in a hospital because of the ancillary health conditions of the patient, obesity or diabetes, where if something goes wrong, you need to have immediate access to supplemental care. So I think we're doing good there, but we want to do better.
I'm in Florida, you're a Florida cracker. I'm going to leave this world one piece at a time, going to the dermatologist. And it seems like every time you go, they're obviously finding things. And then I wish they would just be able to go and take all of the biopsies at one time. But apparently, and maybe you can explain this to me, they get so much for one biopsy, and then the second and the third, and then let's say you got 6, because this happened to me one time. They had some 6 spots they wanted to check. I said, well, just do them all at once. Well, no, they wouldn't do that, because the next time you go, they get paid 100% on the first one, and then 80%.
That's that doctor's choice of doing that.
You understand what I'm saying?
Well, it has to do with a facility charge, and if you introduce 6, you get 1 facility charge. If you do them one at a time, you get 6 facility.
That's the doctor's way of billing the system.
Okay, but and there's a lot of us out there that do that. So it would be nice if you could just go and do it all at once instead of having to go back and back and back and back. So
Yeah, so
That's
we
not
are
the plans.
looking at
Yeah.
a dermatology solution and program for you guys, so. But, you know, on the dermatology side, you know, if they think that there's a spot, just get it taken off. And I hear what you're saying, let's try and get it all off at the same time. But I've seen cases where it looks, I mean, pristine, perfect, and it ended up being a melanoma or a basal cell or something like that. So, you know, we are assessing a program for you guys, so it is something that we're actively working on.
I think that's an important program, especially here, being here.
Oh,
Yeah, absolutely.
Yeah, and you can, if you want to communicate with us, I'm not sure if you're a member of the health center, but who you're utilizing, you don't need to tell the group.
I understand.
If there are other facilities that might not have that schedule of number of biopsies to do at one time.
Again,
Just gotta get us the
I'm
numbers.
starting to become a little time sensitive. The third question we asked is why is health spending, and I would say, the title says, why is health spending up? It should be said more appropriately, why is health cash flow up? And again, that has to do with some timing issues where we're capturing some lag from last year that is having our cash flow go up. But again, every indices that we look at and what's being incurred is trending down, and paid will follow. And in fact, in March, we had a $700,000 reduction. I'm not going to ring the clarion bell for that, because you got to, last year we encouraged not being too exuberant over positive results. This year, we would encourage not having too much panic over what appear to be some negative results. Let time heal all wounds. Where do we need to apply resources? There's some really exciting stuff going on. Our efforts include plan design features, like, again, if we have to put in an extra copay for an emergency room to edge people to more cost-effective care, it's something that we need to openly discuss and consider the relevance of it and the likelihood of success. But we've added significant resources to the mental health impact and thus the health plan. As Kenneth referenced earlier, we need to educate employees about what is available to them and to give them a comfort that seeking care does not put a blemish on them as an individual. It's just a natural part of the health continuum. But right now, we're looking at the possibility of a cancer concierge service, which would be kind of like MAP, but when an individual is identified, they would have a cancer specialist nurse help them navigate, make decisions, adjust timing. I think that has a great possibility. As I mentioned, we're looking at the genomic opportunities for musculoskeletal and certainly for cancers, premature delivery mitigation, and again, I'm kind of excited to see where this heads, but the possibility of a diabetic infusion technology may be delivered through your health center. We're looking, again, adding infusion at the health center. We're adding a full-service pharmacy to the health center. We're excited about that with our local partner, Eric. And that just gives us more and more control over the dynamics and characteristics of health spending.
And it keeps it local.
Right.
And they buy internationally when they need to, right?
Yeah.
Right.
When they stock up their inventory.
That's right. Our work isn't done. It's a work in progress. There are new opportunities arising on the horizon. But I got to tell you, July 2nd, I'll have my 50th year in this business. And I can't tell you I can tell you that I'm more excited now than I ever have been in our opportunity to make a difference for clients, and how grateful we are that y'all have had the courage to allow us to take this path. And we've created a platform with transparent access to data, and it's just really exciting. I would say it if they weren't here, but Lauren and Latasha have become ninjas at managing and actively managing a health plan. We refer to Lauren as the responsible party, thanks to our friends at RSM who kept saying, this will be handled by the responsible party, and every time they said that, it was Lauren's name written next to it. And we can't speak highly enough of their intent and ability, and we just like working with them.
There's one thing I want to say. I know we're respectful for time, but I just want to be careful because I don't know if my gut's telling me that was the dip because of the pandemic and maybe people weren't going to healthcare providers as much. Now that the pandemic is gone, are people coming back? So are we just not seeing an increase, just like a temporary increase because claims are catching up? But are we seeing increases now? People are starting to go back to the normal utilization rate. So maybe we truly weren't decreasing in costs. I mean, we already paid you the bonus, so we can't take the money back, you know what I mean? So it's like, that check is already left in
But that
cash.
catches up
But I'm
this
just
year,
saying that,
so,
maybe we're not really decreasing as much as we thought we were. We were just decreasing because of the pandemic, and now we're going back to the normal levels of
I think
utilization.
if you,
That's why we looked at the Incurred and worked closely with our actuary. Actuaries look at the future, and we try to look at what's going on in the short future, but over the long term. Jay, you want to comment on that?
Yeah, I think we started to see utilization just globally going up when vaccinations came on board a year ago, and doctors' offices were having PPE and allowing it to be open and people going back to get treatment. But I still think, in the next slide coming up, that we keep adding months that are better than they were. And so all that catch-up, I think, was in 2021. And now, here in 2022, are seeing utilization fall.
and then the price per episode, so the price per,
Is
yeah.
staying low. Jay, slide 29 and 30 are you, and if you would comment on that. And we've got some our actuary also does work for 6 other school districts, so he's got some interesting insight for you.
The first slide pertains just to you all.
Oh, you got it.
All the programs that are in place today were implemented in October of 2020. Prior to that, the plan was with Cigna, and an exercise that we've gone through here is to say, if we had stayed with Cigna at a time when we were trending at about 6% a year, and we were to project that to the next fiscal year coming up, beginning in July of '22, and we didn't make any plan changes, and we had the same 6,500 employees on the plan, what would our expected spend in claims alone be if we had kept things the way that they had been? All right, and that's what this $65 million number is. Our expected annual claims over the fiscal year of July 22 to June 23 would be in the neighborhood of $65 million. Now, it's probable that it wouldn't have reached 65 million because you would have been forced to make some kind of plan changes. So even if I'm off here by $5 million, it's still what we think is in excess of what we are going to spend next year. This 48 even as a budget number for next year implies $4 million a month. And Sarah can certainly attest to the cash going out the door that it's $4 million a month, if not sometimes a little higher. This is a budget number, but again, as this Incurred trend continues to dip down, we think cash out the door is going to really be on a monthly basis less than the $4 million a month. Health center, we left the rest of this even, right? We have a TPA, we have to pay them $4 million to pay the claims, but any of this difference year over year really is attributed to the claims. Questions about that? Okay. The next one, Gary had indicated, I've worked not only for you, but I work for 6 other school districts throughout the state. They range in size of their employee base from 600 employees up to 8,700 employees on the plan. And this green line is yours. If you recognize the shape of it, it's the one that we had on the first handful of pages, right, where I took out the page and it just left the incurred. It's the rolling 12-month incurred claims PEPM. You all in the green compared to the other districts that I do work for. This red one in particular has had very, very lousy large claim experience. And this one down here, the blue line that is having negative trend along with yours, you and this group here are the only two that really, if you put a trend line in here, are sloping downwards. All the other trend lines are sloping upwards. They are doing a lot of plan changes in order to get this result. So when you look at these other groups, they're in the 600 to 8,700 employee range. They are all over this same time frame trending upwards where you all are trending downward.
Can you tell us, I don't care who it is, but the blue line, the number of employees or the number of
The blue line has 1,200 employees. And I'm not disclosing it because I didn't go through everybody and get.
No, I just curious. That's all I want to know.
And it's all public sector, I
Size.
understand, but I didn't ask them directly.
Is that the gross cost, or is that just the employer's portion?
This is gross cost.
And do they have a clinic like us as well? Like, they have a similar
Some do,
structure?
some don't. The larger ones do. But this is capturing all their costs.
And I will tell you that, clinics, when you drive by this clinic at 35 miles an hour, it looks like all the other clinics out there. Health centers. But when you really look at the Rosen Medical Center and your health center, for the most part, they leave the rest of them out in the country miles behind. Now, listen, all of them out there are really convenient when they're on site. They're very convenient, okay?
But it's what
That's a
they
good
do,
thing.
what happens
But
inside the
what they
four
do is not tooting my horn, just stating facts.
Tooting Kenneth's horn.
Right. I would, one last thing, I would remind you that when we were hired, it was expected of us to provide actuarial services, and we were asked, what actuarial capability do you have in-house? And our comment was, that's the worst thing you can do, because then we tell our actuary what he needs to say to support our arguments. We fund Jay's fees, but he is completely independent of us. And that's the way it needs to be.
All right, Ken. Oh, you're up.
Mr. Melendez, can I say a few words about the budget before we move on?
Yes.
I just want to make it clear because the team knows what my concerns have been. They've kind of alluded to this concept of the timing between when we incur claims and when we actually have to pay for those claims and how there's been this massive lag over the last 18-month period or so. But what we've been seeing is we're starting to pay out a lot more than what we budgeted in the current year. And so that's what's been very concerning to me and why I've kind of rallied the team around what is going on here. We've really got to dig in and investigate and come to the conclusion that this is about the timing of when things are incurred versus paid. But I think it's very important for us to have this conversation now with the board about what we are actually seeing compared to what we budgeted. We had, over the last 2 years since we implemented this plan, we obviously have gotten our costs down significantly. I mean, that part, we have the data to prove, we have the data to show how we are comparing to other school districts in the area. I mean, getting our costs down has been a huge success. But what we're seeing is that we are still continuing to underfund our plan. So even though costs are down, we still have to be putting the revenue side in to cover the costs that we're incurring. And what we're seeing this year is that we have now basically spent down the surplus that we had been able to generate. So I'm hoping, we got 2 more months in this fiscal year. I'm hoping that we're going to see us kind of land where we don't have to put any more money in. But as we look forward to next year's budget, we're going to have to start talking about how we're going to fund this plan properly, because we are not at a point where we're sitting on this huge surplus that we can just kind of keep saying, let's wait and see what happens. I'm the one that my role is to be conservative enough that we don't end up in a situation midway through the year where we're saying, oh, now all of a sudden, have we blown through all of the money that we had set aside for healthcare? So I want to make it very clear today that we are in a situation where we are no longer in this wonderful surplus world where we're talking about how much money are we going to be giving back to the plan, and there's this huge bank account sitting over here for healthcare.
What's the shortfall, Sarah?
So we were up to 14.7 million or so, and we are, it, changes every month. Jay and I work very closely together every month when we get the numbers in. Latest projection, I'd say we're somewhere around 6 to 7 million that we think we're going to be short.
That doesn't mean you have to fund it. It's coming off the reserves, right?
It's coming, yeah, it will be spending down the reserves.
2018, 2019, you had to move $10 million from the general fund. And I don't think
And
we're
that's the
predicting
position that I don't want us to be back in again, saying, let's just wait till the end of the year and see how short we are. We need to be starting to plan to fund appropriately.
And Jay, didn't you say your state filings indicated that we'd still be in a safe harbor?
We should be. We're not going to be official until we get the financials through June. Every year, we have to send a report to the State of Florida Office of Insurance Regulations that govern through statute 11208 self-funded public entities. And you put forth an actuarial report that demonstrates soundness. And they define soundness as having 2 months' worth of claims in excess free cash, unrestricted, but you can't use it for anything else. And so Sarah's point is that we had 14 million at this time last year. We are eating into it, but I am anticipating that we will still have enough to satisfy that state's test, their safe harbor amount, without having to put any more in. But don't hold me to it. We have to see the final results as of June 30th.
Since we're self-funded, is the revenue, where's the money come to keep it? Is that the claim, not the claims, but not the, what do we call it? I'll use word, the premiums, geez.
Premiums.
I ran out of vocabulary words.
Primarily, I mean, the
Yeah.
bulk of it is the amount, the board contribution, the amount that the board puts in per.
And where does the board get its money from? Because we get categorical funds. Do we get categorical funds for medical? Or does it have to be specifically general revenue money that we put into it?
General revenue unrestricted funds.
And that's normal though, because even if we had an insurance plan, we would have to, most employers do some kind of match or pay a certain amount of that premium, right? So, because even if it's a timing issue, that's what I'm trying to get confused about. Because if it's a timing issue, wouldn't it just naturally catch up? Because even if it's a little bit slower, because that's what I'm trying to get confused is, there might be a timing of the expense, but is there a timing problem with the revenue? Because we collect from the employees every single 2 weeks, right?
No,
And
the
then is
revenue is what this board sets the revenue at. So we determine how much are we gonna put in per employee each year.
Right.
It doesn't fluctuate throughout the year.
So when we do our contribution from the general revenue, not from the employee monies, we look at the difference. How do we project that budget out? Are we looking at to see how much we need to put aside for it? Or we're just banking on this reserve to constantly go down and then add to it?
No, we have. So the last couple of years, we were getting expenses down and we were in a good position where we had this surplus built up. And so we were kind of holding on, there's no need to put more in. And we may even, 3 years ago, we were looking at this forecast in terms of, we may even be in a situation where it's going to take us another couple years before we get to a break-even point. I think the thing that was kind of surprising to me is that we've gotten to that break-even point about 2 years earlier than our initial forecast. We thought we were going to have another year or two where we were still okay, still living in this, with this kind of built-up reserve on the healthcare side, and that has kind of quickly dwindled faster than the original forecast. So now we do need to talk about, does that board contribution need to start being more? And that's a conversation not necessarily for where we land this June 30th, but how we build next year's budget.
Right. And then plus, once we add the new schools, I think Celebration Owl is coming in next year too. Now we have more employees potentially hitting that too, so.
Hopefully healthy ones.
Yeah. Yes.
Okay, all right, we got timing issues, so we need to keep. Is there anything else, Sarah?
No, we're good. I just want to make sure that everybody was really clear and aware of that as we talk about building next year's budget.
Jay, there was one thing after your slide about the trend line.
Oh, yeah, this was taking out that squiggliness of the prior exhibit and the actual trend line themselves. Make it very obvious that the green line is downward sloping. That dark blue line on the bottom is upward sloping, the others are all upward sloping, you all in comparison.
Okay, so on the health center portion of it, I've only got a few minutes, but I'd like to just really hit on the areas that I was talking about from the mental health, the growth of the market, moving to your health center. So I'd like to hit.
Go to a certain slide.
Yeah, I will. Hold on a second. Let's see. Let's jump to, yeah, no, I forgot my glasses. So let's jump to slide 38. Just overall, just talking about the increase in the number of visits that have come to your health center just across the board was up 21%, which is a good thing. X-ray we saw is up 32%. We've had some ups and downs with the X-ray system, but it's up and running. But also, we've also picked up some workers' comp providers that are going to be ordering more X-rays. On the next slide, page 39, the highlight on that was on the physical therapy. So our overall physical therapy utilization is up by 7.4%, but really the new patients up 29%, which is a good thing. We're keeping it in-house, keeping it within your facility to provide the care for not only the injuries, but also things such as post-surgical treatment. So that's also saving the dollar. And then also the dietitian was up 24%. On slide 40, we had a little bit of a gap there because our workers' comp provider, her husband got transferred and she had to move to St. Augustine. But we do have our new workers' comp provider and a second one that had started and that is seeing workers' comp patients. And then on page 42, this is just a mile marker for us. This is the highest score that we've received at 4.9 with over 842 surveys that have been returned. And at the very bottom, you can just see the historical trend of those surveys and the growth. And it's taken time to gain the trust and the patient-physician relationships, but we're getting there. Ms. Castillo, the next one is where we wanted to talk a little bit about the mental health. And I asked each of the counselors, the mental health counselors, the social workers, just to give me a little bit more idea of what's actually happening. And here's the various issues: workplace stress, acute stress reaction. But just like Barry said, if somebody's having constant stress, it can cause migraines, it can cause headaches, it can cause chest pain, it can cause back pain, all of those type of things. Gastrointestinal type of disorders, and nausea and vomiting, those type of things. That can happen, and that will increase your overall cost. But conflict with workers was one of those issues that some of the counselors had presented. Depression, grief, and bereavement. Now remember, during the pandemic...
It looks like a board member snapshot. School board snapshot.
Mr. Melendez said
that last one's probably the best one, the substance abuse, alcohol.
That's great.
Most definitely.
So these are the most common ones that we're seeing across your health center, but also at the steps. I haven't looked at the data from the AP sources or even eHome, but this gives you a snapshot of the most common diagnoses.
And it's important to realize too, go ahead.
No, go ahead.
That these are not just for your employees. We're seeing some things up here are for your dependents. So children with the exact same issues that are coming up.
So the reason I wanted to see this is because, as employers, one thing, we can see what we can control, and it seems like we have two areas that we're able to control, so workplace stress and conflict with maybe we can try conflict resolution. But Dr. Pace, I wonder if we can, maybe as you're thinking about next year and, PLCs and best practices, maybe these are some things that you might consider addressing, since those are things within our control that are clearly causing, some traffic in our mental health center.
Actually, 2 of our social workers have already produced a nice presentation that we're thinking about rolling out during pre-planning on these types of issues for our employees, self-care, and also then looking at other things that we can do to kind of build that in throughout the year.
Yeah.
Also doing a better job of communicating our EAP services, as well as the fact that the mental health services are available in the center. So those are things that we're looking at in terms of our overall employee engagement strategy, goal 2 in the strategic plan.
Thank you.
The next one is the prevalence of your entire population, just basically, the number of diagnosed hypertensives that you have in your population is 1,629. I put that up there because I want to show on the next slide, what is the total population of hypertensives and diabetics and asthmatics that are actually coming to your health center. So you can see your health center is seeing 963 of those hypertensives coming to your facility. Originally, we were at, I think it was last year, we were at 656, and we're at 953 or 63. That's a 46% increase, which is really good that they're in our hands, because on the next slides, I'm going to show you some of the outcomes. If they're in our hands, we can help them with their medications or stress release, weight reduction, whatever it might be. High cholesterol, which is hyperlipidemia, we've increased by 58% market share, meaning your associates coming to your health center for high cholesterol issues. Low back pain, that just made sense. We put in a chiropractor, and why did we do that? Because of low back pain issues, but also to gain more opportunities to have your associates come to your health center. We're up 77%. That's a good thing. Because of the health center, not only because of the chiropractor, and also because of the physical therapy, working together with that provider. The diabetics were up 41%, meaning more people coming to your facility. The one that I'm very interested in now is your asthmatics. We picked up 49% market share, higher, 49% more individuals coming to your health center with asthma. But the next slide, you'll see some of those outcomes are, we don't have people, the fourth one, 2 or more asthmatic-related ER visits in the last 6 months. That's really good, especially what has been all over your cars, the pollen?
Slide 45.
I'm sorry, 45 or 46?
45.
Oh, okay. So, I mean, that's the good news, is at least they're getting what they need, and we have a lot of the meds available also through our international pharmacy program, so they can get those medications to prevent them from the asthma flaring up, but also have the medications available if it does flare up during that situation. That was the most important thing. Here are some of the things that, from an outcome standpoint, if we're capturing more and more of our population coming to your facility, what are some of those outcomes that we're looking at? We're looking at here, like hemoglobin A1C is less than 7%. That's a goal. But if we're going to pick up somebody brand new in your health center, it's going to take us time for us to get that number where we need it to be. Get them on the right drugs at the right time, at the right place, at the right cost, right? But the same thing with your cholesterol patients. This is the outcomes now that we're looking at. Even though we've captured them, now what's the outcome that we're proving the...
You said, sorry, I thought you were talking about...
I'm sorry. Again, here, the hypertensives with their blood pressures, we're looking at these things because these are the things that are going to save you dollars. Many of my conversations with you, it's 75 to 85% of your spend are going to be spent on these individuals. Remember, many moons ago, we started seeing the microalbumins. This is to look for any kind of kidney damage from diabetics and hypertensives. We said, let's bring it in-house. And we did. Look what we're able to accomplish. So as we capture more market share, as we get the data, as we identify those individuals, we're going to be able to respond to what do we need to do to get them controlled, get them what they need to control that chronic condition. Thanks. Same type of thing here. Now we're looking at, did they get a cholesterol level check? And here you can see right across the board we're doing really well. Are they on lipid-lowering medications? Now, not everybody has to be on a cholesterol med. We don't want people to take drugs. But if we can help people, hey, I don't know, say the dietitian, maybe eat a little better, exercise, have more fiber, more what's it called, oatmeal, because it's going to bind the cholesterol, and we don't have to put you on drugs. Because some of these drugs, these are synthetic drugs. Look at the laundry list of side effects, right? So our goal is not to put patients on drugs. That's not the goal. The goal is for them to eat right, exercise, reduce stress, moderation, right? But sometimes we don't have that opportunity. Sometimes we're working constantly, like your teachers, and then they're just grabbing quick food. Or the stress level, remember, stress kills, right? So when you have high levels of stress, if a lion ran through this door, we want our stress to go up. We want the cholesterol to go up. We want the blood sugar to go up. And so we can fight off that lion. But it's that constant elevation that causes damage to the body. And so that's why I'm glad that Dr. Pace is working with social workers, and we can find a way to help reduce the stress as we recognize issues within the population.
And it's funny you say that. When you guys have put in the chiropractor, have you seen the number of pain medication, prescriptions go down? Like,
I haven't looked at that from a cohort, but
We had a report.
intuitively, I remember Dr. Hughes saying that, and
maybe our data guy can look
Our
at it.
opioid
Yeah,
program is
well,
doing
that's different.
extremely well. We've cut from 200 and some odd down to 54. And some, and again, there is appropriate use of opioids. It's just when it becomes abusive is when it's a problem.
I'm going to be optimistic. Obviously, you want to be optimistic. These numbers will, over time, will get better, but unfortunately, I'm not trying to be the pessimist, but as the economy starts to get even worse, good food is expensive, so people revert back to the processed foods, the macaroni, mac and cheese, and all of that, and then it's just going to, then the stress levels go up, and then all these numbers, I'm going through all your lists, I'm like, yeah, that's probably going to go up, that's probably going to go up,
Well, but then we can.
It's nothing against, but this is nothing against you. I mean, it's nothing against the people in this room.
Not at all.
It's just that's the way things are going to probably progress.
We could, yes, is healthy foods eating a little bit more expensive?
Yeah.
But frozen vegetables, I go to Aldi, get a bag of frozen organic.
I do this, we
$1.20.
do that, yep.
So you can do that. You can get that big old bag of broccoli from Sam's for $4. Really? That's not more expensive. It's just the amount, the effort. Versus, I can just drive through McDonald's and pick up a Big Mac. I haven't had one in a long time. I might tonight, yeah. But again, it's that quick, easy fix. But if we can help with pre-planning, teaching, showing, hey, go to Aldi, you can pick up that organic corn for $1.10 or something like that. It's just pre-planning, giving them the opportunity. Maybe once we recognize that there is this issue, maybe the district will have a grocery store or something and buy in bulk. And now, hey, there's no excuse to.
But combining your comment with Mr. Thacker's comment, if we see that that's probably what's going to happen, what are we going to do to jump out there and get ahead of it?
Right.
Yeah.
Ashley's even looking at Uber Eats.
I did my first delivery the other night with my daughter. She goes, "You want to do Uber Eats?" And I was going, "What?" We deliver ice cream of all
I
things.
bet your daughter did it. You did it.
I was driving.
At $5 a gallon, he's going to be driving a lot more.
Oh, yeah.
Sam's, $4.39.
This is an exciting slide.
Well, it's exciting in a way. Again, we want to make sure that our population is getting the screening that they need done. Colorectal screening is not exciting. To get a colonoscopy is not exciting. The prep is not exciting. And going in under general anesthesia is not exciting. But it's something that we have to do. We've got to continue to let our population know, hey, if you don't want to do that, this is an option that we have done. And look, over 426 that we've done. Now, we brought in and we negotiated a spectacular rate for the district through our relationship. That we've saved you a significant amount of money than what would have been brought to your attention. But the areas that we're looking at is, we're looking at how many have been sent out. Okay, great. We ordered it, it was sent to the patient's home. But we're also looking at, are they getting it back? Is it coming back? And if it's not, we're reaching out to that individual. Oh, I plan on doing it during the summer. Well, it's not a complicated process. I mean, it's a process, and then you just put it in the mail. But your health center is reaching out to those individuals. Remember, I said you guys had 22 positives. What was some of the numbers that Barry had indicated? We had an increase in colorectal cancer, Why? Because we're testing. But the sooner we can test, the sooner we might be able to save that individual.
It's
But
happening
this is
sooner.
something that we constantly are looking at, and we're going to continue to get it out there and get it to your population.
The testing for age for people was lowered to 45, and the cancer's becoming more and more common, so we definitely want to lower those barriers so people can get those tests.
We look at, people are like, okay, why is it happening? Well, take a look at the food we eat. Look at all the preservatives in our foods. What do you expect? Your cells only can handle so much.
That's it? That's good. Barry, do you want, or Scott, or do you want to tell them what's in here?
We prepared a pretty extensive analysis, and I prepared I went through it pretty carefully and prepared a separate list of things that you might want, because, unless you want to spend the hours to dissect all of this, which is what we do on your behalf, but these are, I think, the areas that could be of note. And we're going to start generating these reports more often so that we can become closer and closer to the opportunities to make improvements. And we're working to get Lauren and her team direct access to the actual analytical software so they can use all that extra time you've got to dig into data. Jay, thanks for being here. Scott,
I
thanks
think
for
we all
joining
asked our
us.
questions during the.
Yeah.
That good? All right, adjourn.
Thank you.
Anyone?